So, Michael, are they using now neratinib in the GEPAR series? Are you doing any trials with neratinib?
Let me just add one more comment, and then I will answer your question. I have reviewed for ESMO 2016 the long-term follow-up of all adjuvant studies, NSABP, NCCTG, HERA study, and BCIG. So actually what we see, and HERA study 10-year follow-up has been accepted for publication, David Cameron, first author, this week. So what we can tell is metastasis even in the optimal treated patients with anthracycline, taxane, and trastuzumab. The metastasis is not stopping in year 5. It's a continuous process, and especially in patients with hormone receptor positive disease. Number one. Number two, we see a recurrence and metastasis rate as high as 30 to 40% even in the trastuzumab-treated patients if they have a higher lymph node burden, like more than 4 or more than 10 lymph nodes. So there is still a medical need to be solved. With Extenet, I was positively surprised to see that, especially in those patients with a prolonged risk of recurrence after year 3, 4, 5, like the hormone receptor positive, we have a long-lasting, and it's lasting for the next years and more than probably 10 years, effect of the addition, the sequence of neratinib. So to answer your last question, we don't have to do GEPA studies with neratinib because I'm so happy to be part of the extended access program now in Germany, and we have some centers which we are going to have in this program, and hopefully we will have an approval. So patients are coming after their adjuvant treatment when they have finished the trastuzumab and asking us, Professor, what can we do now? Am I cured? And if they had more than 4 lymph nodes, so they're hormone receptor positive, I know they have a prolonged risk of recurrence, and I tell them, or will tell them, well, we have a new possibility, and I think we can cope with the side effects. So it really changed from a small hype to an increasing hype over the years, which is exactly the opposite what we see in the oncology scenery at the moment, or in the last years. So yes, I'm excited. We will be part of the EAP, and I will offer it to my patients.
Ahmad, will you offer to your patients?
Really the topic was well covered by Hope and Michael, but I will add something in relation to Daria. As I am following the program of neratinib, let's say at the clinical research level, I'm happy to see that all efforts are made to reduce this diarrhea problem. And it seems from really clinical trials that by giving this prophylactic loperamide from the beginning and so on, we reduce significantly this problem. So that's really an important information for clinical practice.
Okay. So we'll move on. I mean, I think that we could talk about, before we go on, one last comment about brain metastases. It seems to be a lot of women now relapse in the brain with HER2 positive disease. And it's very interesting. It turns out their survival still is determined by their extracranial disease from the studies, at least the registry studies that we have. But nonetheless, it is an important thing. Do you think there are things out there like ONT or something else, even neratinib, that may help us with the woman who already has existing brain mets right now?
I think, Adam, as I mentioned earlier, whenever the drug to be studied in brain met, I think it's really important to be clever in developing these drugs, because there are risks to, let's say, to draw interesting drug, but not well studied in clinical research. So I think we should look to design studies which tell us if the new drugs, any new drugs, could prevent or delay. Honestly, I am following all the new drugs studied, in brain met, progressing on everything, systemic and local therapy. And we have one response to two stable diseases. And it doesn't mean anything. So back to my comment, we should be clever there in designing.
Think about prevention as opposed to treatment. Hope, would you agree with that?
And we know sometimes we cannot prevent completely, delaying as long as possible this problem, because this really in our clinical practice is a major problem.
There are actually some published data that suggests that we may be able to predict who has a higher risk of getting brain mets or not. Obviously, it's a bigger issue in non-HER2 positive disease. But if we could, I think we start with treatment trials even though that's not as appealing, ONT-380 does certainly show some activity with capecitabine, and there are going to be patients who had brain mets on the neratinib capecitabine trial. There's other oral tyrosine kinase inhibitors that are being used, poziotinib, some other drugs. And I think once we start seeing that we're seeing effects, then what we do is move them into prevention. And certainly neratinib has had that course too. Lapatinib a little less exciting data overall, but still showing a delay in, or a reduction in number of brain mets. And so now we'll see ONT-380, which clearly seems to be able to cross the blood-brain barrier and very potent, because once you show activity in established brain mets, then you can move it into the prevention setting.
Okay.
If I could add something, we know that in the first-line setting, the incidence of a brain met is very low, let's say, but increases with time. So for clinical research purpose, I think it's important to take the first event of CNS event, and from this event, try to avoid subsequent event.
That's a very good, I see the strategy,
avoid
the growth of new micromets or whatever,
in other words, we are enriching,
that's the sentinel event as a brain met.
The population to look the efficacy of any drugs whenever the drugs.
So rather than treat the ones that are growing and untreatable, you treat somebody after they already had a brain met, because they're going to get more.
And then you delay the time to progression of a new one.
Correct.
Yeah. So let's